be great if, as we start to talk through this next section, if you think to yourself about the ward where you work or about the setting where you are, and you think about a patient you've had that you feel had some falls or had a history of falls, and think to yourself, would any of this information or how this is presented, would that have affected that patient? Could I have done that a bit differently? So in a sense, I'm going to get you to go back in your mind, think about a couple of scenarios you've encountered, and just try to replay them with this information that you get as you go along. So I'm just going to give you a little bit of overview of the evidence. Now, you will know a lot of it, so I'm not going into it in a lot of depth. But what I'd like to do is go through a qualitative review of the evidence from an older person's perspective. So I'm going to talk about studies that interview older people about falls prevention. So I want you to keep trying to get yourself to the point where you put yourself in the patient's shoes. Then I'm going to move on to talking a bit about the patient and staff response to education in falls prevention. But I do want to allow a bit of time at the end to talk about a community falls prevention program we're running where we're using older people as peers to provide education. So I think it's very important that we get out into the community, and I think the new program that you've obviously got coming out sounds like one we've had in WA a couple of years, which is fantastic, of actually going and getting people to exercise in their own homes, because we know that some people don't like to come to groups, and so having something in their own home where they feel... your own home is often a very comfortable learning space for you. You feel comfortable there, you feel you can take things on, you can feel confident to try things out without feeling people are staring at you. So can be a good place for older people to learn. It's a great place to sit down at their kitchen table and just chat with them. Older people's groups are the same. So going and speaking at senior citizen centres and having older people go there is a great way to work. Wouldn't it be great if there was this sign up when people came in the door of a hospital saying to them, you know, by the way, be aware that the most common adverse event that happens here is falls. Because how many of our patients actually completely let down their guard? I've spoken to patients, many of them, and so has my colleague Steve when we've done our earlier studies, who are astonished that anybody ever falls over in hospital, because you never see it. It's not in the news. We keep it to ourselves a fair bit, and if you're a patient, you don't see anybody. That's in fact what we've got a few patient quotes where our patients have said, oh, I've never seen anybody fall here. So our patients often have no idea that falls are an issue, and I'll get onto that later to tell you why that is problematic. Why, although you don't want to scare people about falls, if you've never seen a car accident and they never reported them in the paper, then you wouldn't see any particular need to leave your seatbelt on, because you think, well, nothing happens, you put them on, but you know, there's no car accidents, is there? It's that kind of awareness. It's important to be aware. And when we don't want to scare older people about falls, we don't want to throw the baby out with the bathwater where they're not realising that falls are an issue. So, you know, falls are still occurring, and I think that's an important point for us to bring up as falls champions. So we're not going to bring it up in a depressing way and say to our colleagues, you know, we've got to all get on to looking at falls on our ward. Falls is everybody's business. We want to bring it up as saying, yes, falls are everybody's business, and here's the plan we're following. So whilst we can be aware that we are slowly, I think, driving falls rates down, I think we need to be aware it's a serious issue and we can't let it go. And I've recently done an audit, and I'll talk a tiny bit about it, in a West Australian hospital where falls gradually went up, and they called us into audit. And I was not surprised, because through my informal channels, I had heard through colleagues and just through various the forums I attend, that the attention to falls had gone down. And so I think if you remove your falls champion from the ward and you decrease your reporting back to your board on falls and you stop paying it close attention, I think whilst we can sometimes, I agree, feel a little bit despondent, particularly if we have a SAC1 incident, we go, oh my gosh, falls, we can be a bit despondent. I think we'd be truly shocked if we took away our attention, and you'll be astonished at how your falls rates can climb up. And this hospital was certainly astonished in a bad way at how they thought they had a falls rate, but it escalated up as soon as they took away some of the FTE and some of the attention on it. Okay, the issue is when sometimes our research tells us we're still not completely 100% clear on the absolute ideal combination or bundle of interventions that should be offered. But what we do know is that when you offer good care and you offer a range of multifactorial interventions, that they work. So we are on the right track. We know that you shouldn't do things in a blanket way across the board. So you can't say in your hospital, I'll get low beds in and that will fix our falls problem. I'll get sensor mats in and that will fix our problem. I'll give everyone an exercise program and that will fix our problem. No, it won't. Each patient that comes in, you need to say, what does this patient need? If this patient needs a special bed, then we'll get one in for them. 1 week you may have 4 patients that need that bed, and another week you might have 1. 1 week you might have 2 people that need a sensor alarm, another week you might have none. So there's going to be some things that go across the board for every patient. For example, I was mentioning this yesterday talking with someone else about pressure care, that every person over the age of 65 should be above the standard level of pressure care immediately, because the standard won't be enough for 65-year-old skin and bone. We know that there was recently an acute trial in acute care that didn't show any effect, and they used, I think, a very particular limited bundle of interventions. So that was a classic case to me of trying to say, put in a set of multifactorial interventions and see if they work. I don't think that will work. I think we need our interventions to go across the board, but we need to pull our bundle out individually for each patient according to what they need. We have our basic standard, and I'm going to put to you that I think our basic standard should include formal education for every patient that comes into our hospital who's able to receive it. We've done some studies and some very large studies looking at patient education, and we've been able to clearly show that when you add that on, you reduce falls. So besides what you're already doing, if you add patient education to your mix, you reduce falls down. When we published our work, one thing that I think I want to emphasise is we completed it in a realistic manner. So we delivered our education on real wards in real time with nothing different other than our educator coming onto the wards. So we didn't actually set the ward up or change the environment or get special nursing staff in or do anything different to what was happening, other than the falls prevention program that people already had in place. We found that we significantly reduced falls by approximately 40%, and we reduced injurious falls. But importantly for us, and the work I wanted to get on to talking to you about is how we've unpicked our result for this to know exactly what happened, is that falls were also reduced on the ward for patients that didn't receive the education. And the important point there is, if you've got a ward and 60% of the people have cognitive impairment on it, it's really important that you provide good care and good education for the 40% of patients who don't have the cognitive impairment, so they can be well armed to be part of the team, they and their family, to help you on the ward. So that now you've got a spare minute to get to the patients who need more time who've got a cognitive impairment. Because you can feel comfortable and sure that the person without the cognitive impairment knows why they should ring the bell and will ring it. You don't need to keep worrying and walking by their door and thinking they're going to get up, because you've had the discussion, you know they know what's happening, you've clearly understood, and you're going to be fairly sure they're going to ring the bell. We had very, very low falls rates among our patients with good cognition because they took that on board. That leaves you more room for the people that you've asked to ring the bell, but some of them are going to forget. And so you need to remind them a lot more often and check they've got the bell and go back and speak to them and see if they need anything. And it gives you more time to deal with the people that there's really not much point giving them a bell because they don't really realise what a bell is for. You need another strategy. Not as a one-off, not patient education and we relax back the rest of the time. Patient education in addition to our normal things we're doing for people. Remember that the key thing that is surprising to a patient is that they're no longer in control of their own body. It's one of the key reasons falls occur, because if your leg always carried you around and now it suddenly doesn't, you're not kinesthetically used to your leg doing that. We've all had that problem. If your back is sore and you suddenly go to stand up out of that chair now, instead of your normal movement, it might be quite stiff and awkward and you're not really sure how to get up. So the patient is often quite surprised themselves at how their mobility's changed. But more importantly, or as importantly, they're now in a very unfamiliar environment. They're not in their own setting. If they're at home, they've probably geared up to have furniture around where they can put their hand on it. And that's the same with the patient. They're now in a hospital room. It's completely unfamiliar. As I was saying before, that's where I often point out to patients, you know, this room is interesting. Every piece of furniture is on wheels. Very different to your home environment. And remember, they've now got staff. Remember, in a hospital, you know, the hospital I worked at, you know, has about 800 beds. They have 5,500 staff. You know, if you're a patient, there's an overwhelming number of staff now, you hope, in charge. You don't know what you should do. It's all very unfamiliar. And then there is a ward culture. Sometimes wards can seem these very big, bustly, unfriendly places. And you feel as the patient you're the last kind of cog in the wheel. So that all leads to this perfect storm where the patient tries something that is dangerous or unsafe because of that combination of factors. So that's why falls occur in the last analysis. I think a lot of times as health professionals, we make the mistake of ascribing the fall to the patient's risk factors. Okay, the patient is confused and they've had a stroke. That's only one tiny aspect of it. If the patient is confused and they've had a stroke, but they've got someone working with them who's clearly helped them to understand what they can understand, and they've got their family members sitting there and they've got their equipment in place and they've got staff helping them to remain continent, the risk factor of them being confused and had a stroke is very much mitigated by the care they're getting. So looking at the patient's risk factors is one aspect. Looking at your staff culture and how the ward is acting is another big aspect. Really, if you want to prevent falls on your ward, you need the patient, the staff and the environment to come together in a linked up, cohesive way. Because that's what's going to help you reduce falls. You need the patient to be part of your team. Because remember, falls happen when the patient's by themselves. So you need to be sure that when you're not eyeballing the patient, they know what their role is. The ward that I recently did the audit on, one of its problems was it was very cluttered and a lot of clutter up and down the corridors. I think that has two problems. Firstly, it isn't good for patients that walk out in the corridor because they can't get to the rails and walk. But to me, the bigger problem on this ward was that it stopped staff freely being able to walk up and down past rooms where patients would be able to see them and where they could see patients. Because there's so much clutter, it's hard to just go as a staff member, I'll walk briskly down the ward and glance in the rooms. And even though I'm the physio, if I notice one of the patients getting out of bed, I'm not due to treat them, but I think, oh golly, they shouldn't be getting out of bed, I'll pop in and help them. There was one ward in this hospital that had a very high falls rate, and wasn't just because staff on that ward had poor culture. It was because it was a particular ward, medical ward, a lot of elderly people, everybody very ill. So, the types of wards where if you're looking in your hospital, you tend to have that little ward where it's a bit of a spiker. But it was having a particularly bad time. And it's an old hospital where I was, and it doesn't have a great layout, but they'd done the best they could in that they'd put mainly patients with cognitive impairment and people at very high risk in the corridor that was closest to the nurses' station. So it wasn't really close, it's just not a great layout, which isn't helpful for them. But they'd done their best to try and group people. That corridor was very cluttered. And another day when our auditors went back, not only was it cluttered, but the ward round had moved down a bit on that corridor and had completely filled up the corridor. Maybe 8, 9 people all around a trolley. And further down, the other ward round, 8, 9 people around a trolley. So not only was the ward now cluttered, actually nobody could walk down it. You had to walk around the ward. It's kind of like a T. You had to go around, come up the other way. So only nurses that really needed to get into a room were kind of going around and trying to edge their way by the trolley. Anybody like me who didn't need to go in that room would just go, well, I'll just go the other way to the therapy room. So that actually obstructed anybody from supervising those patients at all. So if I'm a patient sitting in that room and I vaguely look out, I'm not going to see a nurse going by because nobody can get by. There's so much clutter. So I think it's well worth thinking about keeping our corridors clear so that the patient can easily see people going by and we can see people going by. And the last thing, which I think is terrible, is to have our rooms or wards so cluttered that the family can't fit in. So I went to this ward and the patient said to me, well, it's a bit busy and the doctor was here and the nurse was here and there's all those people and so my family's downstairs having a coffee. I'm like, oh my Lord, I want the family in the room supervising the confused person and making them feel at home and reminding them who they are and where they are. So unclutter is really important for our patients and families, and not just because they trip over things, but for that reason of being able to watch and keep our close eye on everybody. Remember that our falls, we know, when we think about epidemiology, they're unwitnessed, they're usually related to toileting, they happen near the bed, they don't tend to happen out in the corridor. A lot of them do happen in the evening or early morning, and they happen in kind of waves. And we know that falls are happening at these wave times. You know, that when you look at these, again, falls from New South Wales, and you can see those little waves. They're happening in the morning as people get up and need to go to the toilet and move around and nurses are busy. Happening again in another little wave when people get up after lunch and start to move around and go to the toilet. And they're happening in a smaller wave in the evening as people try and go to the toilet and go to bed. They're having that in that little wave. The thing is, that's not news to us, but it's news to the patient, and it shouldn't be if we've given them good education. So I ask, when you ask patients where they think they'll fall, I ask them, they think they'll fall out there in the corridor. When I go out here, I'll be careful. But back in here near my bed, nothing will happen. I'll just get out into my chair. So we need our patients to actually, and I often say that to my kinesthetic type learner patients, where I'll say, see this little square here, and the patient will sort of look vaguely down, and I'll go, just this little square, just here, where this, and I'll stand there and I'll go, that little square near the bed. And I get the patient's attention, they look there and they go, just there, and I go, yeah, just there in front of the chair. Can you imagine a little white square with a cross? And they go, oh, yeah. And I go, that's where about 80% of the falls happen on this ward. And they go, oh, okay, this is the place to be careful. Now I put my seatbelt on. Now I'm careful because I realise, actually, I have to be careful when I get out of bed. That's not the walking out there is hard, but this bit's a bit tricky too. You've got to actually watch what you're doing. So that's what we need. We need to give our patients that information. We know that patients have very clear perspectives. They're not always the perspectives that we would think they'd have. And their perspectives revolve around trying to test themselves out and waiting to see if help will come and not understanding about how communication happens in hospital. So we know that patients have these thinking patterns that are leading them to take risks. So here's our comment that I had up before. You know, this is what a lot of patients say. You know, I just feel really embarrassed to ask for help. I don't like the idea of someone coming into the toilet with me. I've had many a discussion with a patient. When we're having education in hospital, we're not talking esoterical things. The sort of discussion I'm having with a patient is, nurses have special training where they know how to take someone to the toilet, but they're not really staring at you go to the toilet. That's a discussion I'm having. That's what your patients are worried about. You think they're worried about having a stroke. No. They're worried about you go to the toilet and somebody comes in with you. And so, that's a discussion. Our patients are very anxious about, some of them. But do they have that discussion? No. If they haven't had a good discussion with a nurse about toileting and how when someone comes, we'll take you now. Don't feel anxious about that. It can seem a little bit odd, but we'll deal with it carefully. They need to feel comfortable and have that discussion. To be that person that when you come in, the patient is like, oh, great, you're here. The other nurse told me this. What does that mean? When our educators come on the ward, a common thing they have is, oh, it's great you've come. The doctor's been. Can you explain to me what he's told me? That's what we want our patients to do. Want them to feel comfortable to speak to us. Remember, our patients don't think they're at risk of falling. We know that our patients, because they've said this to us verbatim, Dr. Angel Lee's done some great work on this. Our patients are very respectful and trusting of health professionals. And they tell us this overtly. I've had our patients tell our research assistants in our last trial, who rang up 350 people, our patients have said, I'm not doing any exercise because a physio didn't tell me to do them. The patients say, I don't know anything about falls prevention, and I'm sure if I need to know, someone will tell me. So if you don't tell them, they don't see any need to know. They don't see that there's a reason unless you tell them. They interviewed patients who had been already deemed to be at high risk of falls based on their nursing assessments. And they asked the patients, what do you think might make you feel afraid you might fall? And 50% of patients said walking outside in the room rather than, going to the toilet. They also found that patients that didn't think they were likely to fall didn't think there was any worry about falling. That's what I was saying to you about safety. If patients don't think there's any likelihood of falling, they don't picture on any consequences. So they just think, oh, falls aren't anything. Or if they happen, you don't hurt yourself. They don't think actually falls can cause a serious problem. These patients, all of whom needed assistance and were at high risk of falls, 50% of them said they felt confident or very confident they could get out of bed without help. This is that old thing that patients get so indignant about. Yes, the physio told me I need help to walk, but I'm not walking. I'm just getting out of bed. I'm just going to the toilet. I'm not walking anywhere. That's what these patients are saying too. And 55% said they felt they weren't at all likely or only slightly likely to fall in hospital. They didn't think there was any reason. So similar thinking. When the UK did their national falls audit, they found that 82% of bells were in reach. Okay, but that's a worry, isn't it? Because the 18% that aren't in reach mean that people who need our help can't get it. And have a look again at a comment from our patient about ringing the bell. This patient was ringing his bell a lot, but he needed a lot of help. He couldn't see where things were. Whereas I didn't ring my bell not because I didn't need help, but because I knew if you ring too much, people get cross with you. Okay, so somehow that patient has picked up that message. Once they've got that message, they're going to need a nurse with education experience to come in and to say, you might have forgot to ring your bell. Make sure you ring it and have a little bit of a discussion. It's really important to us. We want to be here to help you. And opening up that dialogue again. It's important we thank our patients and we go, it's great you rang the bell, fantastic, it's such a relief. If I, as a nurse, know I can walk off down the corridor and you'll ring if you need, I'm feeling really comfortable. This is great. Thank you. That's the sort of thing that gets our patients feeling confident that we're caring about them and that they're doing the right thing. We did our Safe Recovery program, which we're now doing in quite a few hospitals. In our program, we know that we give people this multimedia type education where we show them a DVD and a workbook and we follow up with them. We sometimes give them as little as 2 sessions, sometimes a little bit more. Essentially, though, it's a ward level intervention. We deliver it by a physiotherapist, but it can be delivered by nursing staff. And we also give staff a little bit of training, but it's very minuscule because staff have their own falls prevention training. We just tell them about the program and our educator feeds back to staff as she's doing education. So our educator might go back to the nurse manager on the ward after a week and say, or 2 weeks at certain times and say, oh look, by the way, 3 or 4 patients mentioned that they were struggling to use certain walking frames. Or 3 or 4, we've got a particular patient that they're really feeling anxious about ringing the bell, or, so we'll have that discussion. So our patients have a clear plan. So that's a really important thing. So if you meet any of our patients who've had the Safe Recovery program, they've normally got a clear plan and it's often written down. We try to get it written down. So their plan will be, I've got to practice my exercise, and I've got to walk around the room only with the nurse. Here's the feedback from our patients. Now, I just want to point this out because we point out carefully and seriously to our patients when we do the education about the risk of falls in hospital. But I just want you to read those comments. This doesn't sound to me, and I think you can feel reassured, talking about falls prevention doesn't get people feeling afraid. It gets them feeling well prepared if they've got reasonable levels of cognition. Notice again, here's these comments. I'm surprised because I didn't think anybody falls in hospital. This was a male patient. You brought me to my senses. What this man was going on to say is, I was just doing everything myself and I knew that was really risky, and this has really alerted me, actually I'm being really silly here because if I fall over I'm not going to get home. So what am I doing? I'm saying, it's really brought me to my senses. And this is an interesting thing, isn't it? For people that haven't been to hospital, need to keep in mind that other people need help too. Because if you're a patient in a hospital, you ring the bell and you think, well, I've rung the bell and now the nurse will come. Oh, no, they don't come always straight away. It just takes them a minute or 2, or maybe they're just right at that point in a room with someone else. Oh, okay, right now I get that. There's no reason you necessarily know that if you don't visit hospitals a lot. This is a common comment, very useful for people who haven't been in hospital before, because a lot of our patients feel uncomfortable, haven't been to hospitals much, haven't had a condition where they need to recover and aren't sure how you recover safely. These are people that haven't had any education. This is an older person, we've asked them why they fall. I don't know. So they don't know why they've fallen. Now, I bet you knew why they fell, but this person who's been interviewed after a fall has no idea. That's a worry, isn't it? Because you know why they fell, so you think you would know what you'll be able to do to prevent it, but they've got no idea, so why would they feel motivated or understand? If you come in tomorrow and talk about exercise or ringing a bell, will they realise it's because they fell? If there's been no connection? When I did an audit that included some SAC1 incidents in a hospital recently, in Perth, we had a lady who fell 3 times. She had Parkinson's disease. And she had a couple of other conditions as well. And after the 3rd fall, she had quite a serious head injury. And in the notes and in the audit trail, husband has said to the nurse, it's a shame nobody told me about this when she came to hospital. I never realised she would be at risk of falls in here. even though she'd been admitted with falls. And the husband told the staff at week 3, on this third fall, well, yes, she does fall nearly every day at home. But he thought, but because she's in here with nurses, she won't fall. So he was very confused by the whole thing of her falling. Some of our patients do tell us about the bell and their walking aids being out of reach, but many, many more of them tell us about these things. About, I'm worried that help won't come, that's why I get up and do it myself. I thought I should be getting better. Like the physio told me I should be getting better and trying things myself, so I thought that meant I should go to the toilet myself. Difficulty concentrating. Some of our patients are so conscientious. One of them, this older lady, said to me, it's really difficult, Anne-Marie. I'm trying to listen and, it's a shame I'm so tired. This is a lady who had, many serious health problems. She said, I'm trying to listen and I just keep forgetting what's being said. I'm so sorry. It's a person, doing their best in hospital, but actually they're really ill. So, we need to not be surprised if we have to go over things carefully and a little bit at a time and again and again. We have to understand that a lot of the men in our hospitals are keen to decide to do it themselves because they just think, I should be getting on. I'm overconfident. That's what a lot of our men tell us. Look, I'm just overconfident. I want to give it a go. So that's where we need to have that dialogue. Do you think you could give it a go the first few times while I'm here and then we can give it a go by yourself? So patients' thoughts and feelings are the key reason about why they take risks. So how can you address that? The only way you can address that is through proper communication. Because without communication, you won't know what they're thinking and feeling. When we walk by rooms, we want to hear, I always say to my students, we want to hear our patients talking because then we know it's two-way communication. We want to hear what people are thinking and feeling because that's going to help us then to point them in the right direction and to give them the knowledge we have. We usually have some good information for you. I often start by saying that to patients when I'm talking and getting on to what I want to tell them. I say, look, I think I've got some good information about this. The reason I put it this way is because they're an adult learner. I'm not going to say, I'm here to tell you about exercise. I'm going to say, I have some good information that I'll give to you and you can see what you think about it. We'll dialogue about it. I'll give you the information, then we'll talk. I'll tell you about the ward and then you tell me how you're going and we'll talk about it. It's very important. It did worry me when we put this education in. I thought, will patients getting this education, perhaps staff will feel a bit like you've upset the equilibrium. The patients are telling us what to do. They won't like that. And certainly we had a lot of nurses who said to us, it sounds a bit worrying. We don't want patients to ring the bell. They're already ringing a lot. We don't want them to ring any more. But I had a few staff say that. And so this is going to be a worry. So, of course, I thought, oh, golly, let's see what the feedback will be like. As the trial moved on, it went very well, and we're finding it continues to go well. And we've had a lot of staff actually say, come on, why can't we have a safe recovery person on our ward if they're only on that other ward? Staff felt very positive about the educator role because it created a positive culture. They felt that it made it easier to do their job because patients were very engaged. Instead of them feeling like they were nagging the patients, they thought it's fantastic. The patients are kind of knowing what to do. I'm not having to say, can you ring the bell? And then the patient the next minute hasn't rung it. And why haven't they rung it? The patient seems to know what to do. This is great. And also what was an unexpected spin-off was we found that our new graduates and our students became more aware of the right thing to do. It's very easy as an experienced health professional to think everybody knows as much about falls prevention as me. No. If you speak to a new graduate on a ward their first day there and ask them, do you know anything about falls prevention? We've had a lot of RMOs say to us, no, not really. They're just starting as a resident medical officer on the ward. They don't really know anything much about falls prevention. Neither often do our new graduate physios. They say, I know Anne-Marie told me something about it in a lecture. I'll try and dredge it up. They don't know a lot. And so having an educator on the ward just sort of gradually shows them what the right thing to do is, and they pick it up by osmosis. The patients were positive, and then the staff observed that positive response, and they felt they were positive, and they felt motivated to assist the patients. And then the patients gained confidence that the staff will respond. So it tended to be a self-perpetuating cycle. It was lovely for staff. They felt it was very positive that they had a patient who said, I had to remember that I was supposed to try it out with someone. Oh, this is great. And again, it leaves staff a little freer to work with patients that need more help, that aren't going to remember. So let's say our educator meets a patient that needs a walking aid. They can walk by themselves, but they must use their frame. However, they are an older man who thinks that actually they should use their frame, but really they think they'll just use their stick. So when the staff don't keep nagging at them, they keep using the stick. So our educator comes in and has a discussion with them and talks to them and comes up with the goal of, let's get you to use your frame for the next 3 or 4 days, and you'll move towards the stick when you're safe, but at this point we don't want you to fall, and has that discussion. Okay, then the action we want our patient to take, their goal, is to use their mobility aid each time they're going to mobilise. And we go over with them, these are the points you'll use it. Getting out of bed, going to the bathroom, walking in the corridor. Okay, I've got that. Now then we need our staff though to be consistent. So we put up our note on the wall, and hopefully all our staff will say to the patient, how fantastic you're using that aid. It's good to see you getting stronger but keeping safe. And finally, we make sure that both staff and patient realise that the aid, and remember to keep the aid in reach. Because this is a comment about the educator talking about inconsistency. You educate a patient about using their aid, and then a staff member goes in and tells them to do it by themselves, so it makes a contradiction. So our educator can get back to staff and say, do you realise you're giving them a mixed message? Because that does sometimes happen, as you know. Now this again is what we're telling our patients. They're often quite anxious. So when we come back, our patients say, Anne-Marie, I actually did ask the nurse if they could leave my frame in reach, and I didn't get into trouble. Because we're making our patients feel brave enough to speak up. Because in the past, we know patients have had terrible things happen to them, like take the wrong medication, things have done, and they haven't spoken up. We need our patients to speak up. So our education gives them that confidence to do that. I just want to tell you about our audit we conducted recently. When we audited 30 patients, all 30 patients could tell us that the nurse had told them to use the bell, and that they knew how to use the bell. And they said, yes, the nurse has told me I should ring the bell if I need help. So that was good. None of those 30 patients could tell us, this is a hospital that hasn't had our safe recovery, none of them could verbalise to our 2 auditors, who were a trained nurse and a trained physio, that it was about falls prevention. So we just said, well, what would be circumstances where you'd ring the bell? Oh, well, if I need to go to the toilet. Oh, yeah, okay. Any other reasons? Oh, even if I feel unwell, I'd ring it. Oh, that's great. Any other reason? Well, I suppose if my family came in and I was worried about, I'd ring the bell. So none of them verbalised, I would ring the bell because it's to keep me safe from falling over. The word fall never crossed their lips. And in 7 of 30 patients, the bell was not in their reach. So these were 30 patients who should have had the bell in reach, and in 7 of them it wasn't in reach. Now, you can, as a nurse, run up and down your hopefully uncluttered corridors checking the bell's in reach. But wouldn't a really simple answer simply be, if the patient themselves felt confident as you left the room, to go, oh, excuse me, Anne-Marie, you've forgotten to put my bell back? Because that's what our patient can do if they're part of the team. But if they don't know falls are a problem and they don't understand that falls happen right by the bedside and they don't understand that your wonky leg is why I need you to ring the bell, then they're not going to ask you, they're not going to see any reason why the bell should be back in reach. But our patients who've had our education go, hang on a second, I need that bell. That bell is really important to me. I just want to finish up by talking to you about a peer program we've run. Because I'm the same as you, I think. When people get to hospital, that's one small segment of the population. We need to reach out and get to people before they get to hospital. Hospital is really way too late to start telling older people about falls prevention, really. One of the things we did was hold Well Cafe, where we invited 100 older people to come and tell us about falls prevention. So we didn't tell them, they told us. And we asked them how we should provide education and where it should be done and what you should do. And then we took their suggestions and turned that into a package so that we could deliver things the way we thought people would receive it well. And one of the things we asked them in a separate way at that Well Cafe, we said, I said to them, because I got up and gave the opening presentation, and I said, look, I speak to a lot of health professionals and they want to tell you about falls prevention, and how would you like them to tell you about it? What would you like? What would you like them to say? And overwhelmingly, these tables of 8 and 10 people around their tables, 100 people, they said, we just want them to treat us with respect and empathy. We just want them to put themselves in our shoes and realise that we are aware we're getting old and our legs have gone a bit wobbly sometimes, and we just want people to feel positive and treat us positively and have some respect. That's what we want. Why do people lack self-efficacy? I come back to my point, because if you've set them a goal that's low, they know you think they can't achieve anything. But if you set them a goal like that and you treat them with respect, they know that you believe in them. And that's just what these people are saying. And also that caring and trust and respect. Why is it so important to get people's families in? Because we hardly know them from a bar of soap, but their family know them well, so let's discuss it and let's get a trusted person to help them take on the message. I've sat with older people, particularly men in hospital, and I've had this discussion with them about you should use the walking frame, and they're like, I don't know, and I've said it would be good, I'm not telling you to, but it's important. Your leg is weak and it is an important step in a safe recovery. And then their wives come in the next day and I've said, let's discuss it with your wife as well. Had the discussion and the wife's gone, use the frame. And the husband's gone, okay. So, they've got their communication of 50 years and they know how it works. And the wife knows exactly how to say that. I could never say that, but she knows. What we did was we had some people that were out doing presentations already, so we gave them some training, but then we created a new package where we gave some new older people who are peer educators, they're volunteers. We gave them information about health behaviour change and about adult learning. So we gave them some of those tips that I gave you first up. And then we did a training package for them, and we sat them down and talked to them about how you might give a presentation. So they go out and they meet groups of older people anywhere, like bowling clubs, 30, 40, sometimes 50 or 60 people, and they stand up as a retired older person and say, I'm here to tell you about falls prevention. This is what I'm doing, this is what I know about it. And they do that session. As part of doing that, I did one and made a video of it so they could look at that and give themselves ideas on how do you fit telling people about falls prevention in an hour? What do you do? How did these people respond to these older people? Both our groups, which was good, both our peer groups significantly increased their belief and knowledge about falls afterwards and felt motivated. So we were delighted, really showing that if you get an older retired person to get up and speak about falls prevention, the older people in the audience will take it on. Because why? Because it's a peer approach. But we found also really pleasingly that our intervention group was more clearly likely to undertake and have a clear action plan. And we have worked with our new peers on this. So we said it's really important that when those people go away, they actually know what they're going to do. And so what we found was people that had our peers that had that training were able to impart that. So everybody who had some peer education went away going, great, I'm really going to do something, and gee, I didn't know falls was such a problem. But what was really pleasing was the people that we thought got our real, I'd call it our super program, super duper program. Those people, when we asked them what their plan was, they were able to say, well, I've got to recheck my glasses, make sure I've got them right, and I've got to take up some kind of exercise, and I've got to remove some of those hazards around my house. So they had their plan. So peer education by these volunteer peer educators, I think, is a great way of spreading the message around. We did find that women were more significantly likely to engage with the message than men. And we are now thinking that what we need to do is train some male peer educators just to speak to men. They were going out to speak to men. And we also found that people who spoke to a health professional about falls were also more likely to engage. So that was a great message for you as a health professional, that people, if they've heard something about it, are likely to engage.